He'll let you know. Yeah.
Good evening and a delightful welcome to Medical Mondays with Dr. O. This is a platform where we pick the brains of medical experts and highly qualified professionals to contribute to help you have a strong health and strong future. It's a new month, and this evening we will be having an update on COVID-19, what is new. Dr. Gertie Anyanwoke, an infectious disease expert, will be having that discussion. It's time to introduce the O and Dr. O. Dr. Toyin Okwesami is a family practitioner, HIV specialist, CEO and medical director of Gennesaret Medical Center. Welcome, Dr. O.
Thank you so much. So much appreciated. Good evening, everybody, and welcome to Medical Mondays. So on Medical Mondays, as Honorable Gustav just said, we share medical information, but we do not establish medical relationship. We don't establish patient-doctor or doctor-patient relationship. So we will give you information and you're free to ask any questions you have. Tonight, we have our very own Dr. Gertie Chimeka Anyanwoke, who is a thorough and compassionate internist and infectious disease specialist in Boston Rouge and Gonzales, Los Angeles. She earned a medical degree from the College of Medicine, University of Lagos, completed her residency at New York Medical College, and subsequently finished a fellowship in infectious disease at North Shore Long Island Jewish Health System and NYU Medicine Program. She is board certified in infectious disease. Dr. Chimeka Anyanwoke has multiple community awards, as well as being a member of AMA, ACP, IDSA, and AMPA. She is the medical director of Infectious Disease Associates of Baton Rouge, as well as Baton Rouge Multi-Specialty Care Center, Baton Rouge, Los Angeles, amongst others. Dr. Gertie Chimeka Anyanwoke is the chairman of AMPA Louisiana chapter, as well as the chairman AMPA National Infectious Disease Committee. She is very involved in her Nigerian community and is currently the president of the United Nigerian Women Association, amongst other responsibilities. Back home in Nigeria, she also has 2 chieftaincy titles from her communities. So join me in welcoming Dr. Chimeka Anyanwoke. You have the floor.
Thank you. Thank you so much for that very kind introduction. I'm going to proceed to share my slides so we can hit it up. Okay. As I've been introduced already, today we're going to talk a little bit about COVID-19 and any other information as well as updates since the last time we did this. Okay, 9 more. I'm trying to play it. All right, so I want to start this talk by saying we should all be smart. We should inform ourselves from the correct sources. We should follow accurate public health advice from WHO, NIH, CDC. We should also follow news on latest coronavirus updates from trusted news sites. When when we see something that may not be true, we should avoid spreading those rumors because that's how they get to be circulating. Always check the source that you're getting information from. In this day of social media, where somebody can get an information, it's so easy for us to just push it to other groups that we're in without even checking it. So the advice is that we don't spread rumors because we all have to start from us. Each one of us have to hold ourselves responsible. So if people need information, go to WHO, CDC, NIH, and other local sources, like whichever state you live in, go to their health department and get the correct information. We are just coming through another wave of COVID with COVID-19 associated hospitalization among unvaccinated patients going through the roof. So to the point where it was said that it was a pandemic of the unvaccinated. Every state in the United States have gone through this or is going through it. Most of the states are getting better right now in terms of the rates. When COVID first started, we look at the age-adjusted COVID-19 associated hospitalization rates by race and ethnicity, and you can see that minorities seem to be more affected than white people. So, like I just alluded earlier on, the new coronavirus cases in the US by day has been decreasing. It's been decreasing now for some time. And I mean, it's heartwarming that we are at this phase, but we cannot let our guards down because the virus has shown us that it can mutate. And then we have winter that's around the corner. So we should be vigilant. Also, we're getting to the time of the year where we go see families and friends and all that. And we may be so excited, we may let our guards down. The percentage point difference between white vaccination rates and Black and Hispanic rates fell across data sources in the US. And this is mainly attributed to, when the Delta wave got to us, I think that was like early July. And when a lot of people were being affected and a lot of people were dying, I actually saw in my clinical practice, that a lot of the people that were hesitant to take the vaccine actually came in asking to take the vaccine, to the point where one time I ran out of vaccines in my office. So data points also show across all the other people that are collecting this data that it did decrease the percentage point difference between the rates of white vaccinated people and the rates of Black and Hispanic, basically minorities. And you can see it for yourself from CDC, KFF, all those data that they've been collecting. So we know that the risk for COVID-19 infection, hospitalization and deaths is different by race and ethnicity. This is actually better because this graph is from July. The earlier graph from last year, 2020, was worse in terms of cases, hospitalization, death. Minorities were having more cases, more hospitalization, and more death than white people. Again, the average number of lab confirmed cases by date of report is actually decreasing. This data is up to October 1st, but we now have data up to October 31st, as at earlier today, that shows there's a steep decline in the people that are getting COVID. And why is that so? And myself and other infectious disease doctors, and of course other doctors around, we think that vaccination is beginning to take effect. Also, some people in the communities that have been exposed and probably developed some immunity. So I think in the population, as of today, we have people from 12 years old and above that are that can take the vaccine. I think you have like 78.1% of the people from 12 and above that have taken that at least one dose of the vaccine. So you see, if you add that to the people that have gotten infection and develop some immunity. You see that the rates is increasing, and that might be helping the amount of infection. How effective is vaccination? I just wanted to go back a little bit and look at diphtheria cases in the past. You see when diphtheria started in 1910, and by 1940s, the vaccine was introduced. By 1965, it was very difficult to find cases of diphtheria. Pertussis, the same. Measles, mumps, rubella, they're all the same. You see when measles, you look at this cycle of measles when it first started, and by 1968, when they introduced the measles vaccine, see how it progressively thinned off. Now, it's not to the point where it's zero. And we all know that. We have anti-vaxxers in our midst that do not want to vaccinate the children because of some beliefs that they hold. But you can see the effect of vaccination. It is clear. I wanted to show this to say that it is not new with COVID-19 vaccine that we're having 2 doses, 3 doses, 4 doses. I just wanted to show this plethora of different vaccines that we have for childhood immunization in the United States. You see some of them is 3 doses, some is 2 doses, 3 doses, some of them 1 dose. And even for the adult vaccination, we have some of them that are 3 doses, 4 doses. This is still for children, 3rd dose, 4th dose, 4th dose. And so it is important for us to realize that because this COVID-19, the way the pandemic came, everything is happening in front of everybody. Now we are all experts at COVID-19 vaccination. And so we are all live watching the CDC ACIP panel debate on if they should approve the vaccine or not. Before, we didn't used to do those kind of stuff. And that's because of the nature of how COVID-19 vaccine has affected the whole world. And so people are watching the sausage being made in real time. Under normal circumstances, the scientists would have figured out, okay, we need 3 doses. And then for the people that are immunocompromised, they probably need 4 or 5 doses. We have vaccinations like that. And nobody ever made this kind of fuss about it before until now. So COVID-19 vaccines, what should we know? We should know that the vaccines are mostly safe. The fast-track development was as a result of the advancement we've had in technology, that there's been a lot of researches done on coronaviruses. COVID-19 is not the first coronavirus, right? We had, before SARS-CoV, the first SARS in 2003, we had at least 4 common human coronaviruses that usually cause like the common cold, catarrh, and stuff like that. And so there's been a lot of researches that have been done. And then the way that COVID was a pandemic and affected world economy and government and school and everything else, there was as a result of that, there was an unprecedented global partnership and funding too. Let's not forget that the federal government in the United States bankrolled the vaccine and told the pharmaceutical companies, you don't have to worry about the money. And so if it was the pharmaceutical companies that would have put up their money, they would have gone through these phases the way that they would have gone. Because normally it would have taken the FDA maybe 6 to 12 months to even analyze the data and tell them yes or no. But because of the pandemic, because of the paralyzing effects of the pandemic, they have rerouted all their other workers to just focus on COVID, at least for that period, to be able to give this approval or no approval. And so a lot of things have worked well that wouldn't have worked normally because of bureaucracy, reciprocism, and stuff like that. COVID-19 vaccines have been proven to be effective. The vaccine side effects are mostly mild to moderate. And if somebody were to have any other side effect that they had concerns, just call your doctor. Full vaccination, if you use Johnson & Johnson, maybe 1 dose, and then you get the booster, which is the 2nd dose. I really honestly think that they are going to still fine-tune the amount of doses. I don't know that we are totally sure yet. And that's because, like one of my infectious disease colleagues said one time last year, he said that it's like building a plane and flying the plane at the same time. So you're going to figure things out as you go. I do not think that anybody knows for sure right now everything that there is to know, or in fact, some of the other things that might be important to know. We are going to find out some things in future. So seropositivity rates in immunocompromised groups and healthy healthcare workers after COVID-19 vaccination. The reason I added this is because I know that since the inception of COVID, I've been talking about immunocompromised patients being at risk, also with vaccination, that immunocompromised patients may not, have the uptake of the vaccine and show their seropositivity rates as much as the normal population. This graph here is just supposed to help us depict that. So for healthy healthcare workers, right, they had 98.1% seropositivity. What is seropositivity? It's like when you get the vaccine, a lot of times, maybe 2 weeks after you get the vaccine, somebody draws your blood, you will find that your body, your immune system has produced immunity, which is antibody against the COVID, which is the antigen. Now, remember that the vaccine is supposed to be mimicking COVID. So it mimicked COVID. The body recognizes as COVID and formed antibodies against it. When you find that antibody in the blood work, it's what is called seropositivity. So that in people that are healthy, healthcare workers, it was 98.1% of the time. For HIV patients, it was 94.6%. Now, remember now, not all HIV patients are necessarily immunocompromised these days because of the medication. Some of them are well controlled, and so they're not necessarily considered that much of an immunocompromised condition. But in total, HIV patients were shown to have 94.6% seropositivity. People with solid tumors, when you say solid tumors, it's like maybe liver cancer, kidney cancer, lung cancer, they showed that they had 82.4% seropositivity. Now, look at hematologic malignancies, 54.7%. Why is that so? I mean, part of the reason is also because when you're going to produce antibodies, you're going to need immunoglobulins, right, to produce the antibodies. And where are the immunoglobulins produced? The immunoglobulin is part of the hematologic system. So it's not surprising to me that patients that have hematologic malignancies tend to show lower seropositivity rates. And this is why we are so concerned. If I or you or my friends have a family member that has a malignancy, be it solid tumor, be it hematologic or other kind of tumors, we want to be very careful because we may not have any issues to be afraid of. Maybe we are not immunocompromised. But if we carry that virus, we may not even manifest any symptoms, but we may be able to transmit it to this family member that has perhaps a solid tumor or a hematologic malignancy that may now show symptoms, and not just show symptoms, may show severe symptoms to the point where they may not survive it. And that is the crux of the matter. So even though they are vaccinated, the vaccination only produced this amount of seropositivity. For the hematologic malignancy patients, 54.7%. I know that we all saw that Colin Powell died as a result of complications of COVID. He was said to have prostate cancer, which is considered a solid tumor, and he had multiple myeloma, which is considered to be an hematologic malignancy. So you see, he was at a very high risk for getting COVID and dying as a result of COVID, despite the fact that he was vaccinated. And why is that so? This here explains why. Patients with autoimmune disease, it was 83.8%, and patients with solid organ transplant, 37.2%. Now you may ask, why patients with solid organ transplant? We, the doctors amongst us, and even the patients that have had solid organ transplants know that they give them a lot of immunocompromising medications that can bring down their immunity. When your immune system is suppressed, it's very hard for that immune system to now mount a sufficient immunity by producing a high level of seropositivity on that vaccine. So this here just tells us the incidence of anti-spike antibody response. So like I said, solid organ transplant patient is actually between 14 to 58%, autoimmune rheumatologic diseases between 74% to 100%, cancers 51% to 95%, and hemodialysis patients are also considered immunocompromised, and that's about 96%. What are the risk factors for diminished antibody response? I just mentioned about solid organ transplant patients. They have anti-metabolites, mycophenolate, tacrolimus. Shorter time after transplant also is a risk. Older age of the patient that has solid organ transplant is also a risk. For autoimmune rheumatic disease, we have, again, anti-metabolites like methotrexate, B-cell depletion, corticosteroids can be risk factors for diminished antibody response. For cancer patients, we have the beta cell chronic lymphocytic leukemia, that's the CLL, patients that are older and have cancer, patients that are on therapy, patients that have poor disease response, they are all at risk. And then hemodialysis patients, especially if they are older, especially if they have lower lymphocyte counts. So far, there have not been a clear observation of a surge in severe COVID-19 among vaccinated solid organ transplant recipients as at this time. For autoimmune rheumatic disease, there's modest impact of tumor necrosis factor inhibitors. And for cancer patients, the most with solid tumors had good response. For hemodialysis patients that are not immunocompromised, the chronic disease has been associated with weaker response to vaccines. So who needs a third dose of COVID-19 vaccine now? People that have been receiving active cancer treatment for tumors or cancers of the blood, people that have received an organ transplant and are taking medication to suppress the immune system, people that have received a stem cell transplant within the last 2 years or are taking medicine to suppress the immune system, moderate or severe primary immunodeficiency, such as the George syndrome, Wiskott-Aldrich syndrome, and active treatment with high-dose corticosteroids or other drugs that may suppress your immune response, especially if it's corticosteroids that have been on for about 6 months, usually affect immune response. And then advanced or untreated HIV infection. Like I said earlier on, if a patient's HIV is well controlled, their risk factor is not that much different from the normal population. So what are typical side effects of the COVID-19 vaccine? We all know tiredness and headache, fever, chills, pain or swelling at the injection site. If people get anything more, they can call their doctors. Some people can take over-the-counter medications to relieve some of the symptoms that I talked about above, like Tylenol, aspirin, antihistamines, ibuprofen. Again, it is important that we remember to continue our hand hygiene, wearing our mask, physical distancing as much as possible. Also, I think people should continue doing contact tracing, especially the healthcare areas, isolation and quarantine measures if somebody has been exposed, or especially if they are not vaccinated. And then good ventilation, and of course, vaccination. That's one sure way of us minimizing the effects of COVID and trying to get out of this and probably get back into our normal lives. I had said before that the difference in the manufacturing of vaccine so rapidly this time is as a result of multiple factors, and I had mentioned some of those factors. Those factors include I said fundings that were available. Scientists had a head start with the worldwide research on the coronavirus, SARS and MERS viruses that happened in the early 2000s. The studies also overlapped. They began production early because the governments were funding this stuff. And then there was, like I said, less retipisins, and study vaccines actually worked. So is the vaccine safe? I would say yes. As of today, 2:34 p.m. my time, Central Standard Time, we've had more than 7.08 billion shots given worldwide. In the US alone, we've had 422 million doses. And then you could tell how many people have fallen off and died as a result of getting the vaccine. But we know how many cases of COVID we've had and how many people have actually died. Therefore, the vaccine is way, way, way more safe than getting COVID. I talk about, I seem to come back to this slide a lot because some people have it in their head that the vaccine, especially the newer vaccines, will alter their DNA. That is absolutely not true. The vaccine actually comes into the cell, uses this ribosome, which is in the cell cytoplasm. You see here, this is the nucleus, this is where our DNA is. The vaccine cannot actually have any meaningful interaction with this DNA. It stays right here in the cytoplasm, uses these ribosomes and other enzymes here in the cytoplasm to be able to produce the spike protein from that messenger RNA. That spike protein now goes into our immune system and uses like the dendritic cells and is able to stimulate our immune system to produce like beta cells, T cells, CD4, CD8, killer cells, and all those nice part of our immune response that helps us to keep us safe for when we now come in contact with the virus. Now, myths versus fact series. This is it. I've heard that COVID-19 vaccines have negative long-term side effects. Is that true? So here is my response. Millions of people have received COVID-19 vaccines, like I mentioned above, and there's not been any long-term side effects that have been detected so far. No non-live vaccine has ever been shown to cause side effects years later. A COVID-19 vaccine is a non-live vaccine. So if none of the others so far has caused it, and we have been vaccinating people for more than 200 years, I do not see why COVID-19 vaccine will now be the first one to cause those long-term side effects. The COVID-19 vaccine leaves your body within 72 hours. Your body makes antibodies after the vaccine, and that is what sticks around to protect you, like I've said above. Serious side effects following vaccination are extremely rare. However, they do happen. Our patients who are allergic to penicillin, like literally will die if you don't act fast. Those things happen. I have patients who are allergic to shrimp. I have patients who are allergic to like mushroom. That's stuff that nobody has any control about, but that's so rare. But what happens is that that's why when we go to get the vaccine, we tell people to stay for 15 to 30 minutes after they get the vaccine, because those kind of rare side effects usually happen a few minutes after you get it. And if you're getting it in a healthcare facility, they usually have like the epinephrine that they can give you a jab, and that will reverse a lot of that allergic side effect. But this, again, is so very rare, but then we have an antidote for it. Now, serious side effects, like I said, are rare, but even if it happens, this is why you're being monitored, it will be taken care of. In contrast, you might experience long-term health problems after getting sick with COVID-19. I still tell a story of one of my friends who's a physician who got COVID in May 2020. And today is November 1st, 2021. She's still having fuzziness when she thinks. She's still having problems concentrating. She's still having periodic headaches that started from when she first had the COVID. And so I have people that are still having shortness of breath, atypical chest pain, people that are fatigued, tired, and just unexplained tiredness. A young man in his early 30s don't have no medical problems, cannot even cut his grass in his house, in his yard, because after he had COVID, he said it's so debilitating. He can't even walk far because he's so short of breath and he's so tired. I started this talk with this slide and I decided to end it with this slide. Let us be smart and inform ourselves about coronavirus. Let's follow accurate public health advice from WHO, CDC, our local health authorities, the NIH. Follow the news on latest coronavirus updates. Follow a news website or a channel that you trust. To avoid spreading rumors, always check the source you're getting information from. Trust me, some people make their websites or news channel look so real that you will be like, huh? It happened to my mother. My mother said she saw this stuff and it wasn't even a channel per se. It was something on YouTube, but because it was on the TV, she thought it was a news channel. And it had a false information about COVID. And it was one of my cousins that forwarded it to my mother. So it can happen to any one of us. Let's just check this information, check the source of the information before we start spreading them around. There is social media. It's very easy to forward, but let's do the responsible thing. Before we forward that information, let's check the source first. I thank you all for this time, and I am open to questions. Thank you.
Thank you so much, Dr. Anyanwoke, for that insightful and detailed presentation.
What is that?
Medical Monday.
Please keep your questions coming in the chat box. You can drop it in there or raise your hand, and then you'll be acknowledged to ask your questions. Remember, Medical Mondays is on YouTube. The channel is Medical Mondays with Dr. O. And you can get all the latest recordings that we have on YouTube, past recordings. And you can also join us live when you hit the notification button and then you like the videos. There's a question in the chat box. But first, Dr. O, if you have a question, you can go ahead.
Thank you so much for that excellent presentation. Thanks for the update. It's exciting that we are actually learning more, that this vaccine is doing something, it's protecting. You know, I give vaccinations to children, you know, adults, and it's the first time I actually stepped back and look at that slide that you put on to show how many DTaP, Hiv, and all of that we give to children, that the multiple doses, this is not new. That is very helpful. I also noted that, you know, you put a slide on diphtheria. Recently, we had about 2 years ago, just before COVID, we had a breakthrough of pertussis in the US that we had to start, revaccinating people with Tdap after all these years that we've been able to suppress diphtheria, tetanus, and pertussis. And people would then come up with, adults would come up with, you know, cough that is just persistent, like it's the whooping cough. That's what pertussis is. So I said all of that to say that there has been so many myths about COVID, that it was made in the lab, it was produced to wipe out the world, basically. And, you know, this is just a virus that went viral, like any virus could do. And even after suppression, we've seen with things like pertussis that they can rear their ugly heads again. And we then just need to re-immunize. But I wanted to ask, some questions, or just one question, so we can leave the floor to people. Some people have asked, can you get flu and COVID at the same time? We're in the flu season, and I get that question a lot. Can you get
the vaccine? You mean the vaccine?
No, the infection. Can you get flu? Yeah.
Yes, actually, I've come up with a test too. That test is a twofer. Yeah, you can get flu and COVID at the same time.
Thank you. Thank you. So over to you, Honorable Gustav.
Right, I have a question of my own, and my question is, after vaccination, as if you are fully vaccinated, can you still get COVID and can you still transmit it?
Yes, sir. The answer is yes, but with some caveat. You can get COVID, but you may not even have any symptoms. And if you have symptoms, it might be milder, and it will be short. It will last long, shorter. It will not last as long as if you did not get COVID. So yes, if you have the COVID, it may not be as much as you will have it if you didn't get vaccinated, but there's still possibility to transmit it, especially to people that are immunocompromised.
Yeah, and also your chances of dying
is much less. And of course, chances of hospitalization is much less. So if you get COVID, like I said, it'll be a milder case, yes, which is particularly part of the job of the vaccination. So vaccination, and I get people get frustrated and they tell me, well, I got vaccinated, why should I still get it? Vaccination is not supposed to mean that you're not gonna get it. Vaccination is supposed to mean that even if you get it, it's gonna protect you. And it's doing that.
Thank you very much. Dr. Bill has his hands up. So Dr. Bill, you can ask a question.
Mr. Doherty.
Can
you? Please unmute.
Yeah.
There you go. Yeah. Please ask your question.
Okay. Yeah. Thank you, Doctor, for a wonderful presentation. I do have a question, however. What is responsible for a lot of developing countries like Africa? It doesn't look like it's a problem there. I know here in the United States, we pretty much stayed home for like a year. For a lot of the developing countries, they only stayed home for like a month. And it doesn't seem to be a problem there. What do you think is responsible for that? Is it herd mentality, or the herd immunity, or what is it? That's my question. Thank you.
Yes, sir. I do acknowledge that that has been a recurrent question. I would say that it's not like it didn't affect them, it did, but not as much as it did on this side of the world. There are factors that are being looked into, and you know that our communities, our society, a lot of us in third world countries are not so big on research. But there is some evidence to say that the population is a much younger population. And in that scenario, if you look at it here, when people were dying, even at the inception, notice a lot of people that were in nursing homes died. And those were a lot of older folks who had comorbidities. So if you have a population where you have most of them are young people, it may not impact them at the same rate that it will impact a population that you have a sizable quantity of the people, a sizable number of the population being older folks with comorbidities. So that's number one. Number two is that people are still looking at, and then another thing is, remember that they weren't doing a lot of testing. So if you had tested a lot of those young people, you probably would have found out that they were exposed to COVID and they just shook it off. I mean, we're tough. We still we're tough. And that's what I mean. Like, they'll shake it up and they'll go out there. People want to, they may sit down at home. You're talking about 1 month. Some of them did not sit for 1 month. They were protesting because some of them live day by day. Okay, so you can't keep them at home for so long. Over here, when the government kept people at home, majority of the people that made certain amount of money per year, they got something from the government. Not back in Nigeria, so you can't expect them to sit down at home. Even if the government says they should sit down at home, they will fight against it. So that's another reason why they couldn't do the lockdown so much. I know people that died in Nigeria from COVID. I actually lost one of my brothers-in-laws as a result of COVID. And that was in Nigeria. I lost one of my friends, my classmate, who's a physician in Nigeria, to COVID. Actually, I lost 2 of my classmates. And then another one was a few years older than me, that his brother is my classmate. So that's another one that we lost. So I know people that we lost in Nigeria as a result of COVID. The thing is that these people that I'm talking about are others that got tested. What about people that died that were never tested? Think about the price. The cheapest place you get a COVID test in Nigeria anywhere would be 25,000 naira. How many people got 25,000 naira to do a test for a virus which they don't have a cure for? I mean, they have not even eaten, talk less of bring 25,000. And there are places that were doing it for 75,000, 50,000. So I was saying the cheapest place you find is 25,000. So there's multiple factors. It's multifactorial. But the truth is that it did not have as much of an impact as much as it had in the Western world. And I think the major factor there is that the population was younger. There are some places where they are suggesting that the BCG vaccination that we took as children might be contributory to the protection. I don't think that has been duly confirmed. And then remember now, Africa is a lot of, at least in Nigeria, we're in sub-Saharan Africa, we have a lot of diseases, and some of these might be crossing each other. So who knows, that might be helping somewhat. But like I said, the issues are multifactorial. Thank you, very good question.
Yeah, that's an excellent question. I just wanted to chip in that testing is a great one that Dr. Chimeka Anyanwoke had mentioned. We don't test. I talked to one of our commissioner for health in Nigeria when I was in Nigeria. One of the conversations we had, she told me that our state had tested the most at that time and told me that they've tested 50,000 people. What's that? So if you don't test, you don't know. A lot of people have COVID and don't have symptoms, like our doctor had mentioned. So if you don't have symptoms, and you have COVID, you're transmitting it, it's not reported. That's one. Another thing is I feel a lot of people are impacted. They say they have severe malaria, they have severe typhoid. I've never heard of something like that before. You have malaria, you have malaria. You have typhoid, you have typhoid. Doc, am I right? You are the infectious disease guru. But now they will say that they have severe malaria and severe typhoid. I say, go test for COVID, it's COVID. And some of the people even testing are doing, false tests. It is, oh my gosh, so much is going on, especially in Nigeria. So there are many reasons why it looks like people are not impacted. My cousin, Akeolugbade, died. When I was in Nigeria, I treated several people with COVID that tested positive for COVID, that had money, they can test. The positive that I treated myself. So I'm not so sure that these African countries are not as impacted. I think a major thing is that we don't have proper records. We don't have documentations. And, so what we have is what we have that we talk about.
And a lot of people get treated at home. They won't go to the hospital because they don't have the money to go to the hospital. So if they die at home, nobody ever tested them for COVID. They will never chalk them to COVID death. It will not be counted.
Oh, I actually have, one of our neighbors, young guy who died of COVID. The death certificate said COVID in Nigeria, but the family said, oh, he couldn't breathe, that it was asthma. he couldn't breathe was why he died. But somebody else who saw the death certificate called me and said, I saw it. It says COVID. Why are they saying he can't breathe? Because COVID in our communities over there is stigmatized.
Yeah.
You know, that's another issue. And yes, they don't go to the hospital.
Yeah. And even if you say that there's a government hospital to go for free, remember when COVID first started, they would wear these suits that look like they're going to the space, and then they'll bring this van, come to your streets, everybody will run away, and then they'll carry you and go. So a lot of people do not want that, because then when you come back, nobody wants to talk to you, nobody wants to deal with you. There's this thing that's now to COVID. Everybody see you, they run away. So nobody wants that.
All right, I see Tawu has the answer, so please you can unmute and ask your question. Tawa. Hello.
Go ahead.
All right, let me read the question. She has a question in the chat.
I'm asking her to, okay, yeah, go ahead. I'm asking her to unmute.
Can people mix match the vaccines? The Nigerians that came got AstraZeneca at home. Can they have our brand here?
Absolutely, yes. Actually, the truth is that they've been doing that in Europe. And then they had some studies that came out there earlier this year that said there was no problem, it was actually okay. And I know that the CDC and the FDA wanted to do their own studies first before they would say yes. However, the CDC did have it on their website for a long time now to say that if somebody was in an absolute pinch, you can mix and match. But more recently, with their data that's out, they said, yes, people can mix and match. But I've been having people coming from Nigeria mixing and matching since earlier this year. I'm like, what do you have to lose? Go ahead and get it. That's a pinch.
Thank you so much. Alicia also wants to know, should a person under 65 on HBP, I think that's high blood pressure,
Mm-hmm.
take the booster?
Under 65 or 65?
Under 65.
So I'm going to go back a little bit. And the mixing and matching thing, the recommendation is still that you take the same one that you took before, but there's no problem if you mix and match. So let me just put that out there. Then for the question you just asked about under 65, the study that the FDA used in approving the booster for 65-year-old and older was actually a study that was done in 60-year-old and above in Israel. For some reason, the FDA decided that they wanted to do 65. Now, if the 60-year-old is a healthcare worker or a first responder, somebody that is exposed to children, maybe they work in a daycare or such like that, I would advise them to take the booster. If the 60-year-old has comorbidities like diabetes and any other chronic illness, I will advise them to take the booster.
Thank you so much. Now, this says that a patient who usually gets his flu shot refused flu shot this year and vowed never to be immunized anymore. He claims that some people and he himself got the shot and they started losing their memory and their teeth after the COVID-19. Is there any relationship between COVID-19 and memory and teeth loss?
The relationship I know about COVID-19 and memory is actually that if you get COVID-19, you can have memory. I just talked about a friend of mine who's still having problems concentrating, problems remembering stuff, focusing. Yeah, that's for somebody that had the infection. I do not know any relationship as of this time between COVID-19 vaccine and memory loss. It's actually when you get COVID, you can have problems with remembering stuff, concentrating and stuff like that. There was something else you said apart from memory. What was the other thing?
Teeth loss.
Teeth loss.
Teeth loss. Oh, I know of the loss of smell, and taste. But that's for the infection, not for the vaccine.
No, teeth, that they lose their teeth, they lose their tooth.
I have no data.
I have not even heard of it.
Yeah, I have no data showing that.
Not,
I don't know of any data telling that. And you know, why people are so distrustful of the system. I think that is mainly a big problem here. People are so distrustful of the system. And I think it's a lot that has been going on in the political space that has really affected people's minds. And so we have to look at this stuff. Those of us that are out here talking about this stuff, I have children, I have a family, I have a mother, I have sisters, I have brothers, I have uncles. I'm telling them the same thing. And myself, I'm taking the vaccine. So does that mean that these people have paid me to kill myself or my children or my family? They have to remember that the people that work in the FDA, the CDC, are also family people that have family members in the community. They cannot be coming here to tell them lies. The people that do all these studies. So if like anybody that takes the vaccine, there's this vaccine site on the CDC website that you can go in and put any side effect or anything that happens to you after you got the vaccine. It may be vaccine related or not, they're gonna figure it out. And so sometimes when they put whatever happens there, whether the person has had stuff like that in the past and it just coincidental, some people take that as a fact. That, oh, in fact, until I took that vaccine, I didn't have this problem. Then I'm like, okay, didn't you have this problem like 6 months ago before you took the vaccine? So it's like they just forget about that. And there's so much distrust in the system. I think that that's something that, you know, we all or the government or somebody needs to figure out how to get back to the right place where people can trust the right authorities. Because if we can't trust these authorities that are putting out these facts for us that are non-political, then we have a long way to go.
Yeah. So, Sister Tower, I'm asking you to unmute so you can ask your question. There you go.
Thank you very much, Dr. Anyanwoke. Nice presentation. My question is not about COVID. My question is one of the graph that you put on the screen about pneumococcal vaccine. The kids get 4 doses, but we adults, they gave us 1 dose. How effective is that 1 dose?
So, so you know, children, if I mean, we've had little children, you see them go to the daycare, they catch this, they catch that. So it makes sense. And then most times by the time you come out from that age group, those factors that are considered for those age group are not necessarily, you know, considered for adults because you would have had all those exposures already. So when you are now an adult, they look at the strains of strep that causes the most problems for adults, and they immunize adults. And you have to be at a certain age. You can get it the second time, 5 years after, 1 more dose after 5 years of getting the first shot of the pneumococcal vaccine.
Thank you.
You're welcome.
So I have a question here on the T cells. The slide you showed, the question reads, what was the level in the HIV population? What was the T cell level?
So
you know,
that's why I put that caveat when I was making that statement to say that patients who have HIV and are well controlled are not considered to be like their levels for seropositivity is not necessarily far from that of people in the normal population. As long as, you know, they are doing well controlled. And most of the people that are doing well and well controlled, they're undetectable and their T cells are usually above 200. I don't think that study captured it. I think it just captured a range of HIV patients. It might be people that are doing well and some people not so well. They really did not differentiate. And you can see maybe that's why one of the reasons why the number came down to 94%. And even at 94%, it's still very good.
It's excellent.
Yeah.
You know, I'm an HIV specialist, and when, you know, in last year, a lot of my HIV positive patients were concerned about COVID. They say, oh, they have underlying medical problems. And I always take them back to what CDC said. When they listed the list of underlying medical problems that cause issues in people who are positive or who test positive for COVID, HIV was not listed, and it's still not listed, because we've gotten a good handle on HIV. And once people are on medication and their viruses are treated to, you know, very, very low, we call it non-detectable, like Dr. Anyanwoke said, then the immune system keeps building up. Do you know that most of my HIV positive patients, they have better immune systems than those who don't have HIV?
Not me. Not me.
Yes. They have amazing immune system, which is the T cells that, that was Dr. Bill who asked the question, that the T cells that he's talking about, they're very strong. So COVID will not affect them like somebody who is immunocompromised, like Power, who have cancer or who have other things like diabetes that is not controlled. So there's a question here that says, how long should one wait to get tested for COVID-19 after being exposed if they are fully vaccinated?
Okay, so what I do now is, it depends. Okay, let me leave what I do now. Let me go ahead and answer your question. I wouldn't, if you've been exposed, I would say a couple of days, you will get tested. So if you found out that you were exposed on Friday, I would be tested today or Sunday. Because the PCR tests are very, very sensitive. They're very good. The test that I would say wait for like 5-7 days would be the antibodies. If you wanted to see that, even then, within a week, I don't think you would have, well, a lot of people would have, actually most people would have developed antibody within a week, but a lot of people also wouldn't have developed. But yeah, for the PCR test, I would say a couple of days is fine.
Fantastic. So follow-up question says, I like the statement you made about trust. Does a negative COVID-19 test result? No, what does a negative COVID-19 test result mean?
So the negative COVID-19 test result, remember now we're doing antibody tests, we're doing antigen, and we're doing PCR. So for the people that are not medical here, the antigen test is the one that's supposed to be the rapid test. It's very good in terms of its reliability, but the best test is still the PCR. So when you have a negative antigen test, which is the rapid test, there are some times where you could have false negative, and you want to confirm that ideally with a PCR test. And the PCR test is the one that they swab you, they send it out to an outside lab. It might take, depending on the area where you are, it might take a day, 2 days, 3 days to come back. So the antigen test is the rapid one. You can get it within 15, 30 minutes or hour. But those tests, even though they are reliable and good, when they say it's negative, most times it is, but a few times it may not be. There's a facility where I cover, it's a state facility for Louisiana. And we've had people come into the facility and they're negative for the rapid test. And then because we do a double, right? So we do a PCR test. Because the PCR test takes a couple of days to come in, we do the rapid test when they come in. And this rapid test is negative, but the PCR test, and a few of them have come back positive. So yeah, that just shows you that the PCR test is much better. So a negative rapid test means that they couldn't find any part of the COVID. So the negativity of the test depends on the test. So an antibody test, somebody that's exposed and you get the antibody test done, say 4 days after exposure, and it's negative, it means nothing to me because the body hasn't had enough time to produce the antibodies that you're looking for. So such a patient might need to come back a week later for me to test them and they'll be positive, right? And then the PCR test, if he says it's negative, I'll believe it. And if he says it's positive, then you want to look at the totality of the patient. Some patients that were positive like 2 weeks ago and they're just looking for a negative test and they continue to be positive and they're asymptomatic, I would not worry too much about them because the PCR test can be so good that even tiny fragments of the virus can be multiplied. So PCR means polymerase chain reaction. So it's like you get this tiny little bit stuff and you blow it out. And so if you have a little bit of the fragment of COVID, you can blow it out to the point where it can be positive. I know you asked just for the negative, then I went all full blown talk about negative, positive.
Fantastic. So, how long are antibodies present after infection? That's a $1 million question.
So last year, when COVID first started, they did a study where they actually cultured the virus. And when they cultured it, they find out that, 1 day it was positive, the virus, the culture was still positive, 2 days, 3 days. And when they got to the 8th day was when they noticed that, it was really nothing there. So that was the reason why they were saying people needed to quarantine for so many days, like 7 days. Because that is from that study that was done with this culture. So most people within 7 days would have cleared, but there are some people that may not clear it in that time. Every one of us is an individual. Our immune systems are different. Majority of us might, go one way, but a few of us might be a little different.
The antibodies, do you remember the study that came out? I think it was around just before summer last year from Colombia that suggested that for people who have been, infected by COVID-19, the antibodies last 2 months. And that's it. We all freaked out because we know that antibiotics will is protective, and we want it to last longer. In SARS and MERS, they lasted 1 to 3 years. But we've seen otherwise now that the antibodies actually last a little bit longer. But, so it varies from one person to the other. I think the question was how long are antibodies present after infection? I think we still research. People are still researching.
There was a question about antibodies being present in the person's blood.
After infection. The natural antibodies developed after COVID infection. How long does it last?
Well,
Miss Belinda, you know what? Let me be clear. Miss Belinda Bryant, where are you? So she can ask a question herself. Miss Bryant? There you are. I'm going to, please unmute. You're muted. You're still muted.
Okay.
Yeah.
You guys hear me now?
Yes.
Yeah.
Okay. Good evening, first and foremost. Thank you.
Good evening.
Yeah. So again, my inquiry. Right now, I'm going to say 4 out of 6 members of my family have had COVID within the past 2 months. So I'd like to know, number one, antibodies. How long are they present since we've all been infected? And secondly, like I inquired, my last born, she's been complaining of memory loss within the last several weeks to me. So what do I need to do about that, as well as my husband?
Okay, so the first part of the question is how long does antibodies last? There have been different studies come up with different things. I think the average is like 6 months. However, there have also been studies that have shown that the vaccines produce way more antibodies than the natural infection. I have had personally patients who've had COVID multiple times. Part of it is because it's another strain And part of it is probably because they probably didn't have maybe enough immunity to mount the defense. And it's going to be different from patient to patient. So if you have a patient with comorbidities that maybe their immune system didn't mount enough response as a result of the COVID, they might be more susceptible than somebody else that don't have multiple comorbidities. You know what I mean? So it will be dependent on one person to the other. But I think averagely maybe 6 months. But I would suggest that after everybody has recovered, at least 2 weeks from their recovery, they should go get a shot. Because what that's going to do is it's going to increase their antibody levels very, very much to protect them, if that's the protection you're looking for. Now, for memory loss, first, did the person have COVID?
Yes, she did.
Okay, so I wouldn't assume it's just COVID, just because in medicine, you want to rule other things out. Take them to see the doctor and have them check it out and see. And if they can't find anything else, then it's probably the COVID.
So
now, I don't know how long the memory loss is going to last. The memory loss is going to last. Like I said earlier on, I have a friend who had COVID in May 2020, and this is November. She still has some fogginess. So I don't know how long that's going to last. And that's what we're talking about the actual long-term side effects or long-term effects of having COVID. The people are worried about long-term effect of having COVID vaccine.
So as a mother, how do I push forward with this? Because this child is going to be on her way off to college in the next few months. So she's very concerned about getting into school, retaking her SATs, and just remembering basic everyday things.
Was she vaccinated? Was she vaccinated? No?
Mm-hmm.
Okay. First, number one, that's one of the things I would do. Vaccinate her and take her to her primary doctor and have them investigate it. We don't want to assume it's COVID. It's probably COVID, but you want to make sure you rule out other important things before you pin it on COVID. Yeah?
So I have a question on behalf of this mother. If it is COVID, if other things are ruled out and she doesn't have anything else and it is COVID, because we know about the memory fog, in your experience, what can be done to accelerate recovery of?
I don't think that we know anything right now that can be done. Everybody's trying different things. I honestly, I don't want to prescribe here, and I don't want to, because that's not what this forum is meant for, especially things that have not been proven. There are things that I have tried, but like I said, my friend still complains of her own effects. Since your child is younger, I'm not sure, to be honest with you. The primary doctor might be best suited to give you the medical advice. I don't want to prescribe on TV.
Understood. Okay. Thank you very much. I appreciate it.
If you please email me, that'd be great, so that we can look into what is going on. It is true, this is a sequela of COVID sometimes. Again, she's young, other things need to be ruled out. But in case we come up with something that is, something new that can be done so that we can reach out to you quickly, that'd be great. The email is in the group chat.
Thank you so much.
You're welcome.
So there's another question here that says, please emphasize to all the use of monoclonal antibodies. A lot of our folks are not being offered this treatment.
That is very true. That is very true, because I experienced it myself. In fact, I was so mad, I wanted to start doing it in my clinic. They talk a good game, but I don't know, I think it's state by state. Every state has a way they handle this stuff. The federal government ships it out to the different states. How they distribute it and supply it is another matter. People need to know that if they get COVID, they can get the monoclonal antibodies to kind of minimize the effect of the COVID. It can actually prevent hospitalization. if you get COVID early, if you get COVID and you get this infusion early. But it's sad. The reason I started out with the distribution of it is I've had patients who had COVID and I tried to get them monoclonal antibodies and I couldn't. And one of the hospital system where I was supposed to send the patient to get the COVID, the monoclonal antibodies, this was a Monday. They told me they can't get that patient slotted in until Saturday. From Monday to Saturday, I'm like, the patient probably would have ended up at the hospital by then, you know, but that's what we're talking about, resources and all. But the issue there was because they were lacking nurses to administer this medication. And people need to remember when they don't want to take things like the vaccine, right? When they don't want to take the vaccine, they don't want to wear a mask and they don't want to do things that are necessary to prevent the COVID, there are consequences. There are a lot of nurses that are quitting their jobs, just plain old quitting their jobs because they're tired. And so it's the hospital system at some point was overwhelmed. You will see people really sick, even short of breath, come to the emergency room. The emergency room is so full and they look at this person and they're like, well, this other one is worse, so you go home. Honestly. And then they have to go home. And, you know, bad things can happen in these circumstances. But the point is, people always kind of had in the back of their mind, if something happens and I get COVID, I'll get to the hospital. If the hospital system is overwhelmed, that's a problem too. We do need to push the monoclonal antibodies, but after pushing it so much and it wasn't there when the patients actually needed it, it's kind of handicapping also. So I actually had a meeting with NAACP and the Commissioner of Health here in Louisiana to talk about this, because a lot of Black people were getting COVID and not being offered the monoclonal antibodies. And just because the system wasn't, you know, rightly set up for it. I think they're trying to improve that now, and we'll just have to wait and see.
Wow. Thank you. Dr. Booker, I'm going to ask you to unmute. Kindly unmute and ask your question. But while you're doing that, Dr. Ademola, Dr. Moses Ademola wrote that there are psychoeducational assessments that could assist the person in eliminating confusion on the sources of the suspected memory loss. And that's true. That's true. Dr. Booker, kindly unmute and ask your question. Also, Dr. Bill, can you ask your question, please? Your question on...
I have a question.
Variation. Yes. Yeah, go ahead.
You want me to do it?
Yeah, well, Dr. Booker has not been able to unmute. Go ahead.
The question is, we have a variation in the protective rate of the vaccines. Is that due to the process of formulation as in attenuation? Or what determines the difference in effective protection of the vaccines? I imagine it has something to do with how it's prepared, and the preparation is attenuation.
So for all intents and purposes, I think Moderna and Pfizer have similar effectiveness. 94.5, 95 is similar to me. Johnson & Johnson, remember now, that's one dose. If you give a second dose of Johnson & Johnson, it will be around the range of Pfizer and Moderna.
Okay, okay.
Okay, and that being said, a lot of Nigerians come and they got AstraZeneca in Nigeria. I've seen a lot of them who got one dose of AstraZeneca. And then they come here and they're here for a week or so or whatever. And they're like, what should I get? I need a vaccine. I don't know if so we suggested them to get J&J because it's one dose. And everyone that I know that have done that has been protected. And they have no sequelae.
Yeah,
I'm unmuted now.
Oh, fantastic.
Thank you, Gertie. And I was the one who want you to emphasize monoclonal antibodies. I've seen so many Black people not being offered it. And I only knew about it because my physician husband, and she's white, went to George GW, and there she said it on her chat. You've seen her, Dr. McBride. Please go and get it. GW has it. But my brother-in-law went to a doctor and he wasn't offered anything. I had to chase him out at midnight to go to GW and tell them, I said you could have it, and he got it. So I said, I know people who got it, tell them you want it, and that's how he got it. So it's that bad. They're not offering it a lot to our people. But thank you for a good lecture as usual. Thank you, Gertie. Mhm.
Thank you.
Bye.
So I was going to add to what you said about the J&J. J&J is actually similar to AstraZeneca. It's similar vaccine make. You know, it's just like Pfizer and Moderna are similar. That's the same thing with J&J and AstraZeneca. So if I get AstraZeneca, yes, I think J&J is a good one to get as a second dose. But you can also get Pfizer or Moderna. But yeah.
Yeah, I recommend the J&J because it's one shot, and they don't usually have the 3 weeks, 4 weeks, 3 weeks for Pfizer or 4 weeks for Moderna to get the second one. If they were going to, so I wonder if they got one AstraZeneca, getting Pfizer or Moderna would pass for a second dose.
Yes, that's the mix and match we're talking about. Yes, and they don't like, you know, even the J&J. Honestly, my personal opinion, I think J&J should be 2 shots. And there are different vaccines, different make. It was a different way that they use in making like J&J and AstraZeneca. AstraZeneca is 2 doses though. But I think they can be forgiven because at that time, the way COVID came, it was like we were just trying to do something to stem the tide. But all said and done, I'm thinking that there might be revisions in the future.
Yeah, Dr. Ho, I have a question.
Yes, ma'am. Good evening, ma'am.
Good evening. Great job. Fantastic job. Now, this COVID doesn't seem like it's leaving soon. So we talked about memory loss, and there was a gentleman that said something, but I didn't quite catch that. So I'm asking the question in light of the fact that you said many people may have COVID and they're unaware that they have COVID. But if they're experiencing symptoms like a memory or foggy memory, maybe not memory loss, depending on their age though, what can they do to boost their memory gain?
That one is beyond my pay grade as at this time, because they are just collecting this data, and I don't think anybody has been able to put up any good study to show that this actually works or that actually works. But they might benefit from the services of a neurologist. I'm thinking because I have friends who are psychiatrists and neurologists, and they are beginning to handle this stuff. They might be able to tell us more if what they think may work. I know a lot of studies are going on because this is really serious. So that's what I would say. It is the potential. In fact, my friend that I was talking about that has the memory loss is looking to retire. One of the reasons is because she can't concentrate during the day and she's a physician. And so it can be debilitating, it's serious.
Yeah, the memory fog is serious. Also fatigue. There's been post-COVID sequela that we're just still trying to handle. I don't know anybody who is handling any of those well yet. Researches are going on. Some people have not been able to return to work since last year. Some with the post-COVID sequela. So if you get COVID and you made out like a bandit, praise God. It's better to get the vaccine so you can avoid that sequela. We have not seen post-COVID syndrome or sequela in people who are vaccinated. Have you seen one, Dr. Anyanwoke?
Oh, I haven't actually. That's amazing. That's amazing.
I haven't. Yeah. So it's better to just get vaccinated and be safe. It doesn't mean you may still not get COVID. you can still get COVID, if it's another variant or what have you. But like it's been said earlier, the course will be shorter. You would avoid hospitalization. You would avoid death, most likely. I think new studies show that it's 3 out of 11 people that die of COVID have possibility of having, have been vaccinated. It will be 3 out of 11 of those who are vaccinated that will die, as opposed to if they're not vaccinated.
And usually they have comorbidities like cancer and stuff like that, immunocompromised. So yeah, there's a caveat to that.
Yeah, people who are immunocompromised, when they get vaccine, COVID or what have you, they mount immunity maybe up to 40%. So they can't mount immunity very well. That's why they probably would also need booster after booster. Here, we don't check antibodies after getting COVID vaccine. I think it's important that we should. Israel does, UAE does. It may be helpful to let people know if they have adequate antibodies or not. So you can even ask your doctors for that. When patients ask me, I check their antibodies, easy. So get vaccinated. Abby has her hands raised. Go ahead. Great. That's my daughter. Go ahead.
Good evening, Doctor. Thank you so much for a very informative presentation. Really amazing. Thank you. I wanted to just mention, I'm sure everyone knows that in Nigeria, the vaccine that's being administered is the AstraZeneca, right? Yes. But for whatever reason, the US has not authorized that particular vaccine. Which is why a bunch of my colleagues from Nigeria had come over and, they ended up taking the Johnson & Johnson vaccine because some other European countries were not recognizing the fact that they have been vaccinated with AstraZeneca. They make them basically quarantine, regardless of the fact that they've been vaccinated. So why is it that the US has not authorized that particular vaccine? Because that is also the reason why people are kind of skeptical about taking it, because they're like, okay, I've taken this one. So why are you telling me that, this particular vaccine is not okay? So that's my question.
Very good question. Very good observation. So I don't want to say that there might be political issues and this stuff. But if you remember now, AstraZeneca was developed in Europe originally. They were supposed to, the US had bought some of their vaccines before they were even manufactured, because at that time they had to, you have to hedge, you buy from here, you pay, and just because you don't know what's going to happen at the end of the day. And then Pfizer raced to the top and Moderna raced to the top, and these had very strong relationship with the US. If you noticed, when AstraZeneca presented their data here in America, there was this kerfuffle. And that was more from the fact that they've had a few missteps, but those missteps are nothing to say, about the effectiveness of the vaccine itself. It's more on the minute details, data, and the way the FDA wants it. So they were approved in Europe. And when they did their study, they did part of that study in Brazil and part of it in the UK. And they had a protocol which was submitted. Somehow, they ended up, I think the one in Brazil ended up giving the patients 1 dose instead of 2 doses. And then the data suggested that the people that got the 1 doses actually did better in terms of effective immunity than the people that got 2 doses. So all that it was like this jumble of data, and it wasn't like you're trying to do a protocol. You're supposed to do the protocol to be uniform. It's like the people that got it from South America, because you have to, now, all this stuff, you have to match the percentage of Black people, percentage of Hispanic, percentage of white people that got it. But when you're putting this, it's like if you give somebody 1 shot, 1 dose or half the dose, and you give somebody else full dose, it's like apples and oranges you're comparing now. And you want to use that data. So, and then they did some further data in the US because they had to. And then they mixed some of that data with the data they did in other places. And at other time, they were supposed to show a data range of certain amount of months. And then they mixed some other data that was, so that's all that kerfuffle that was going on. And that just put the kibosh on it. So, and I honestly, and this is off the record, I honestly believe that if this is an American company, maybe they would have resolved all those things. So they now have to send them back to go and get their data right before they come and present it to the FDA, before the FDA will approve it. I think that's where we are right now. But there's nothing wrong with the effectiveness of the vaccine.
Thank you very much. Appreciate it.
Thank you. So Dr. Booker has another question. She asked, what about the Sputnik Russian vaccine used a lot in the third world countries?
So I will start out by saying that I think it's a good vaccine based on the data that they have published. The thing is, if you remember well, I think it was July last year, they wanted to rush to be the first. Even at the time they were rushing to start giving the patients, right? They did like a phase 1, combined phase 1, phase 2 trial with like less than 100 people. And that's the clinical trial. They were supposed to go to the phase 3 trial, which would have hundreds or thousands of people. They didn't do that. They started administering the vaccine and using that as a phase 3 trial. And then they claimed that they were the first. You know, the Sputnik, what does it mean? Sputnik 5, you know, it's like when they went to the moon, they were the first, right? So they wanted to claim to be the first to produce the COVID vaccine. And that caused a lot of skepticism in the scientific world. Like, you don't do that. You don't start saying you got a vaccine even before you did a phase 3 human trials. And so that made a lot of people back off of it. But when they finished their data, and I have to say that their vaccine is similarly produced like AstraZeneca and Johnson & Johnson, is the same similar method. They produced very good data. Their data actually came out, I think either December or January, like 5 or 6 months after they claimed to have had a vaccine. You don't first of all get the vaccine before you get the data. You get the data in the scientific world before you push out the vaccine. So that's why it looks like people kind of backed off of it. But after they did their data, the data they presented looks very good. And see, I hope that answered your question.
Dr. Booker, I'm sure you did.
Thank you. Yes, you did. Mm-hmm.
I know because that. If she didn't, you let her know. I trust you.
But, you know, it's not allowed in America so far. You can't travel to America with Sputnik vaccine.
I'm not going there.
Well, the deal is we have 3 excellent vaccines. So seriously, I mean, what else are we looking for? Abby, go ahead. You have your hand raised again. Good, thank you.
Yes. Okay, so I have a question for the doctor. I wanted to know what your response would be, because I've found myself in, this conversations, like heated arguments about, trying to basically educate people on taking the vaccine. And the rebuttal is basically, oh, how come the scientists were able to produce a vaccine so fast, and 37 years and counting, we've not been able to find anything for HIV AIDS or whatever, this is too fast, it's part of the reasons why I don't trust it. What would you advise someone like me to respond when I'm being faced with a response like that?
So it's multifactorial, and I wouldn't be in heated conversation. If they want to be educated, you calm down and you educate them. There are multiple reasons why. HIV is a retrovirus. So what does a retrovirus mean? Basically, HIV is always changing. It's like it's man on the move. Before you make the next one, it has changed. So it's like you're shooting at this target, it keeps moving. You can't get a vaccine because if you use the current composition to get a vaccine, the next minute, even if you produce a vaccine right now, the HIV has changed. So that's so frustrating. They've done so many studies, many trials, and the phase 1 will be looking good. Phase 2 will be looking good. We're like, hey, let me sit on my seat. Oh, maybe this one will work. And every time it's like, it's not gonna work. The difference between why we got this so quick is that COVID shut down the world economy. And you know, these people don't play with their money. It shut down everything. It shut down everything as we know it. So they were pressured to do everything possible. So they brought out the money, right? Everybody has intellectual property. All that went away. No intellectual property. All the different institutions worldwide, everybody was bringing their research data to support and help this. So it was like, it's a team effort. We're in this together. Because the whole world was down anyways. So there was no need keeping this your intellectual property. So you see, different universities, different countries, they were collaborating, right? The people themselves were volunteering to do the tests, to do the study. Most times in research, if you have a research for a vaccine and you get 4,000 people, my dear, you have gotten a lot.
Yeah.
This time around, only Pfizer had 30,000 people volunteer, actually 37,700 volunteered. You had, I think, 18,000 something placebo, 18,000, you know, actually took the drug. I think AstraZeneca had 30,000, Pfizer, Moderna might have had 60,000. Those are unheard of numbers.
Yeah.
I have never seen anything like that. And then they had multiple sites. People were volunteering themselves as study material, and their sites as study sites. So you had a lot of collaboration and a lot of funding went into it. And then I talked earlier about, usually the FDA is the one that, you know, certifies anything in the US that we have to consume, especially medications, you know. They have their protocol. If you submit your paperwork there for a vaccine, so let's say you have done, like, you know, phase 1, and then you need people to confirm that this is good, or some certain boards that somewhere that meets whatever. Because of COVID, everybody had to sit down, everybody was doing their job. Even at FDA, when they submitted their phase data, they had to pull people from, what else are you doing? They pull people from everything else they were doing to just make sure that this data came out. Like, they studied it and they gave a no or a yes, so that they can move forward. So that's the red tapeism we're talking about, the bureaucracy. They had to cut all that. That would have taken maybe 6 to 12 months. That was done under weeks. And that's where you see collaboration coming in. So a lot of stuff, and then these trials, the R&D was already done, the research and development, because coronaviruses have been studied majorly in the last 20 years, so much, even before then. But think about, we had SARS, which was like, it looked like God was giving us a warning. And then we had MERS. They are both coronaviruses that they studied so much. So you now lift from that study and you'll be like, okay, COVID-19, you come over here. What do you have that's different? You know? So that's another coronavirus that you want to see, okay, what's different in this particular one? Because you have a lot of basic knowledge already about the coronaviruses. So all this stuff put together, and the fact that with technology is so advanced right now, that they had this technology they've been developing for the past 31 years. They started in 1990 to develop how to use a messenger RNA to cure diseases. They didn't think of COVID. COVID wasn't here at that time. It wasn't even vaccine they were thinking about. They were thinking of drugs, how to make a medication that would cure something, like if somebody has, like, you know, some problems that is protein related, they can just send the messenger RNA, go over there, produce this correct protein, the system is correct.
They were using it heavily in cancer.
Yeah.
Cancer also.
I'm trying to explain it in layman's terms, right? So this technology was being developed since 1990. They hit a brick wall. I think they first did it in mice in 1990 at the University of Wisconsin. Afterward, they hit a brick wall because they said that the messenger RNA is so labile, it's so easy for it, like it's like a runner, right? It wants to go this message, quick, 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 and it will just get destroyed on the way if you don't protect it. So they realized that if you need a messenger RNA to go to a particular cell, and produce antibody in that cell. You have to protect that messenger RNA until it gets to that cell. Otherwise, it gets destroyed on the way and gets unintended consequences. So that took them another 15 years to figure it out. So from 1990 to the year 2005 was when they figured out how to protect that messenger RNA to be able to get to the target cell and do its job. So after they figured it out in 2005, of course, all these venture capitalists started getting into the business. That is how they formed Moderna eventually in 2010. Moderna has never produced anything, but because of this technology that they made their hand on, they were able to raise billions of dollars. They didn't produce anything, no, but they were able to raise billions of dollars since 2010. And then 2020 came. It was like all that opportunity and all that preparation finally met an opportunity with COVID-19. And they decided that, okay, why not use this technology? So people think that the technology was done last year. No, this technology has been 30 years in the making. It just happened to, like, they use it at the right time with COVID. And it was still a gamble, right? But they have had researches. In fact, they tried to produce something for Ebola using that technology. And like your mom just said, they are using part of that technology for cancer patients. So they know to some extent it works. And we were just going to have to take our chances with it. And it works so superbly. Now, I can tell you that they are actually looking to use that technology to produce HIV vaccine. So you can tell your friends and those people that are arguing with you that this particular technology might be able to help us. Now, the fact that HIV changes, we have seen, I don't want to go into too much technicality, but you see, there are different sites on the COVID vaccine. There are different properties that you can use in producing vaccine or medications. So this time they use the spike protein. All the vaccines you see use spike protein, which is that protein that allows the virus to be able to come into our cell, use the ACE2 receptor in our cells to gain entrance. So you want to stop it right there so that it doesn't even gain entrance at all, right? So perhaps we could have something like that with the HIV virus, that the core might not be changing as frequent as the rest of the pathovirus. If that happens, that would be a game changer. So you can tell them they can have hope. And then there's another argument people make about malaria and all. And I know they've been working on the malaria, but then there are different issues, right? Malaria is a parasite. The way malaria gets to us is a little different. But then, you know, as of last year, I was telling people that there's a vaccine coming, and finally, you know, it was approved this year. And we do have a vaccine for malaria right now. It is not even as good as the COVID vaccine. Yeah? But anyways, that's another story. Thank you. I hope that answered your question.
Yes, it did. Thank you. I think I'm ready for my next argument.
And thank you so much. And Abby, thank you for all you have done, getting your friends, colleagues, and peers to be vaccinated. I know you have been instrumental in getting many vaccinated. Thank you. Excellent. Thank you so much for that answer. I mean, digging deep into how we got the mRNA vaccine. You know, if there's anyone on this forum tonight who is still doubting because it's a vaccine, we've never done vaccines like that before, which is true. Now you know, it wasn't the making. That was God protecting us. That was God preparing the way. God already knew that COVID-19 was going to happen. And this technology has been in the making 30 years before. Tell me that is not God. Tell me what could have happened if we didn't have the vaccines to be tempering COVID as it's doing now. So God got us. And I just praise him. Thank you so much.
Thank you so much, Dr. O and Dr. Anyanwoke. Now it's time for the medical moment.
Wow. God has been good to us. Despite 2020, look at us, we're all still here. We can talk about COVID. We can talk about new things happening with COVID. God has blessed us with our very own Dr. Gertie, Chimeka, Anyanwoke. Wasn't she fantastic? To God be the glory. I just feel like praising God right now, but I'm not going to break down praising God right now. I just want to praise God. So on Medical Mondays, for those who have never attended, we actually recognize people who bring 10 or more participants to the forum and who attend, or who bring 20 people or more. And, you know, we call them VIPs or champions who bring 20 or more. Dr. Jagbe has been our only champion who brought over 20 people one time. Dr. Ajay, Ephraim and Hannah Ajay, had, you know, over and over, even this week, they won. But they've told me enough is enough. Stop giving us all the gifts. In fact, they have given a lot of their gifts away. So I want to recognize somebody on the forum tonight who has always been here, who actually one day, almost angry, you know, got in touch with me and said, why haven't you sent us the reminder for this week? And I'm like, oh my gosh, you know, somebody who really wants to learn about herself and take care of herself. This is what this forum is about, for us to learn more about the knowledge that God has so kindly given us so that we can better take care of ourselves. You know, whether it's people of color or not people of color, we need to be educated about health-related things, especially in these times, and to just be healthy so that we can have a strong future. Health is wealth. So tonight, I'm going to recognize Dr. T. Dr. T will be our award winner for tonight, and we're going to send her an Amazon gift card that was donated by our last week winner, Sister Lola. She donated that, Sister Lola Aromolaro. So Dr. T, I'm going to ask you to unmute. Thank you. So if you can fit say a word, you are a winner tonight. We'll be sending you an Amazon gift card.
I'm so grateful, Dr. O, and for the amazing work you have been doing. God bless you. Thank you very much.
Thank you. Thank you so much. We appreciate you.
Thank you, Dr. O, and congratulations, Dr. T. And that was the medical moment. Before we go, Dr. Gertie, Anyanwoke, your concluding statement.
So we know about COVID vaccine and mutations. I think this is the only part, or one of the only other parts that I didn't touch during my talk. Mutations. I'm personally worried that if we don't have enough people vaccinated, then the virus, because the virus needs a human being to propagate, then the virus will keep propagating in people, and it is in propagating itself that it can make that mistake and produce a shoddy copy of itself that becomes a mutant strain. And who knows if that mutant strain can become so active that it might not be recognized by the immunity that we now possess from getting vaccination. I am in mortal fear of this. This is one of the reasons why I give these talks as much as I can. It doesn't matter how busy I am, because I think every little water helps. People should remember that we all need to vaccinate so that we can decrease the ability for this virus to mutate. Because if this virus mutates to the point where it becomes a mutant of significance, then we are potentially in trouble, because whether you've gotten the infection before or you've gotten vaccinated before, it may not work. And that's the fear that I have. Having said that, we still have to live our lives, but for those of us that have younger children, grandchildren, now that they've approved between 5 to 11 years old, let's get them vaccinated. The younger kids might be affected, but for the most part, they do fine even when they're affected. The problem is that they might end up transmitting it to the older folks that might have a problem with it because they have comorbidities or other things. So let's all remember, because of the mutant strain, that we should do everything that we know how to do to mitigate, but also remember to have our families and friends in mind, and to celebrate life and to do the things that we usually do, enjoy our lives, and protect ourselves and our families. I know that it's going to be Thanksgiving in a few weeks, 3-4 weeks, and Christmas right after that. If we all make sure that we're vaccinated and our families are vaccinated, so we can enjoy our time with our friends and our families. That's all I ask. People should go get vaccinated if they haven't. If you know somebody that hasn't been vaccinated, Dr. O can cut this thing, whatever question they have, if it's not answered already, I am ready to answer them. Our community needs to be vaccinated. I keep harping on this stuff. Our community needs to be vaccinated because we have the most cases, we have the most hospitalizations for COVID, we have the most deaths for COVID compared to our size in the population. We make about 13% of the population, but we have more than that in cases, hospitalizations, and deaths. So in conclusion, I am begging people to go get vaccinated and to continue setting measures to protect themselves and their families. Thank you.
Thank
you so much. Go ahead, Dr.
So next week, we're going to have Dr. Bill come talk to us about nutrition. It's very important. Diet is important in our health today, especially because of all those things that should not be in our food that is in there. And stay tuned. In future, we're going to bring nutritionists who will come, a lifestyle medicine-bodied physician, actually, who is going to come cook for us on Medical Mondays. Wouldn't that be fun? I'm looking forward to that. And I'm going to throw this out. Please, if you know anyone who knows I grow, growing plants in the house, I think it's called hydroponics. I don't know. If you know anyone who knows how to grow those plants in the
hydroponic.
Thank you. Please contact me, email me. We'll appreciate that. Thank you so much. Thank you again, Dr. Chimeka Anyanwoke. Thank you. Appreciate you.
Thank you.
Thank you very much. This is the Medical Mondays, and we have been listening to Dr. Gertie Anyanwoke. She is an infectious disease expert, and tonight we discuss COVID-19 updates, what is new. It's been a wonderful conversation, and thank you so much for choosing health and wellness as a priority. Thank you so much for coming. Remember, you've got all the information for you to live a healthy life for a strong future, strong health. We'll be back again next week for another educative session. Till then, stay blessed and good night.